Hello, my name is Michelle Bates, and this is my Extreme Makeover presentation for NU 713 Organizational and Systems Leadership for the Advanced Practice Nurse. The purpose of this presentation is to identify a time when a miscommunication in my workplace occurred, explain how the miscommunication happened, and the variables that could have influenced the situation. I will also discuss how conversations can influence the culture of an organization using specific concepts of communication, including patterns of relating, patterns of meaning, ways of talking, listening, and being, and innovation. The goal I have for my organization is to change from one of habit to focusing on innovation through these core concepts of communication. I work as an ER nurse and have an extreme example of miscommunication in the workplace. A few months ago, I was assigned to the code room that's used for cardiac arrest, respiratory distress, or any other extreme emergency. I had an insulin overdose come in and place the patient in the code room. In the middle of treating this patient, we received a call that a full cardiac arrest was arriving by ambulance in less than 5 minutes, so we needed to move the insulin overdose to a regular room to prepare for this new patient. The miscommunication happened when the nurse assigned to the room with the insulin overdose thought that I would keep this patient along with the full arrest patient that had just arrived. She made the decision that ended up getting her terminated to take another one of my assigned rooms that did not have a patient. The entire code team and I worked on the full arrest patient for almost 2 hours before they pronounced him dead. During this 2-hour code, not one single person checked on this patient. When I was finally able to leave the code room, I walked by the insulin overdoses patient's room and noticed that he looked very pale. I went to go get the glucometer to check his blood sugar, and it was too low to read. I ran to get the nurse that I assumed had been taking care of this patient to get the physician to put in orders to give the patient some D50. And she stated that that was not her patient, but it was mine. After we got the patient stabilized but gave him 2 amps of D50, I had to get the charge nurse involved, who stated that the other nurse was supposed to have taken care of this patient. The patient, however, did make a complete recovery, but had I not walked by that room and noticed how he looked, this could have been a very different story. The patient could have died due to this miscommunication. I'm not exactly sure how the miscommunication happened, but there was definitely a breakdown in communication between myself and the other nurse. Did the nurse just choose not to care for this patient? Did she assume that I was to continue the care of both the critically ill patients? But the major miscommunication came when she failed to get approval from the charge nurse for the change she made in room assignments. The variables that allowed the miscommunication to happen were that the other nurse was a new grad that was just released from orientation a week prior and didn't have enough experience in the unit. Because she was a new nurse, did she have fear of taking care of the critically ill patients, which made her choose a room that didn't have a patient? A new grad only received 6 weeks of orientation. When you pair that with being a new grad, she likely did not receive enough training before being released to work on her own. Unfortunately, this had not been the only problem between myself and the other nurse. She had been written up previously and blamed me for it. But more than likely, this happened due to the fact that we were extremely busy that day, had a full load of very sick patients, so she saw a way to reduce her workload. Conversation themes within my organization include the shortage of nurses within my unit, constantly being asked to work overtime when no one volunteers to work when no one volunteers to work extra shifts. We are left with unsafe patient to nurse ratios. Because of the long nursing shortages, most nurses are now talking about leaving, going to travel to be able to make more money. and they are not rewarding the staff who have stayed loyal to the organization. When we address these concerns with administration, we receive no answers, support, or change. These issues have created a culture of overworked, frustrated, undervalued employees who are considering leaving to go do travel nursing, and some leaving the profession permanently. Organizations are formed by two patterns: patterns of meaning and patterns of relating. Patterns of meaning are the four individual organizations' mission and vision for the organizations. Patterns of relating is how people interact with each other. Currently, the culture of my organization is one of frustration. The lack of communication between administration and staff, the constantly being asked to work overtime due to staff shortage, the unsafe patient-nurse ratios are causing nurses to consider leaving, either to travel or leaving the profession altogether. With the nurses leaving by the dozens, administration does not appear to address these issues or have any resolution to the problem. Relational leading requires an increased interaction between management and staff. The result of these interactions is a coactive process that ends with a new language that generates a new way of leading. Relational leading creates a cohesive group. In my organization, there is a serious mistrust between the staff and administration. Administration really needs to work on ways of talking to the staff and actually listening to the concerns that the staff bring to the table. With every conversation, it's a new opportunity for change and improvement. When listening, we must listen purposefully. We must be aware of our verbal and nonverbal cues. And another part of relational leading is just being present in the moment. In complex relational health care, it requires thinking outside of the box for innovation to occur. Most new innovations are centered around radical ideas, and failure is bound to occur during this process. Innovation in healthcare is built on evidence-based practice and requires collaboration. To move toward organization as conversation, I would focus on my organization's vision and mission and lead by example. Be able to open up the line of communication between staff and administration by encouraging a horizontal communication. I would encourage honest conversations about the barriers that we are facing currently in our workplace that are hindering innovations, and I would be open to discussing the uncomfortable topics that are being ignored within our current culture. Improving patterns of relating would require combining rational leading, practical judgment, responsive relating, cohesiveness, and the two patterns of relating, which are talking and listening. Relational leaders have practical judgments and have the ability to naturally improvise. They understand how to create stability when necessary. Responsive relating is being able to find cohesiveness between the staff and an organization. This also requires intentional and purposeful ways of talking and leading. To change the story to one that facilitates innovation, my organization must turn away from the old mechanistic planning, use both and type of thinking, and strongly encourage and support the innovators. Mechanistic planning can be useful at times, but also can discourage innovation. Both and thinking leads to increased communication and help motivate innovators. So for the extreme makeover, we're going to flip the story. While being assigned to the code room a few months ago, I received an insulin overdose patient. However, before I could get this patient completely stabilized, we received a call from EMS stating that we had a full cardiac arrest coming in. I had to move quickly to get the insulin overdose patient moved out of the code room and into another nurse's room. Mindfulness. I found the nurse taking over this patient and gave her bedside report as quickly as I could, but also allowing time for her to ask questions while also trying to prepare for the cardiac arrest that was arriving any minute. Patterns of relating. The nurse, assuming care of the patient, took control of the patient immediately, checking the blood sugar, followed the insulin overdose protocol without hesitation. Relating and meaning. The other nurse, listening and understanding the urgency of the insulin overdose, responded quickly and effectively, and the patient was able to make a full recovery without any drop in blood sugar and avoided having to be sent to the ICU. Thank you. That is the end of my presentation.